Welcome to the Cataraqui Woods Dental Implant Institute, a nonprofit organization with the mission and vision of furthering both education and research in the discipline of oral implantology. My name is Dr. Waji Khan. I'm a dental surgeon and also the course director for a series of online lectures provided as a service to the profession of dentistry to deliver a literature and knowledge-based approach to dental implant education for practitioners interested in learning more about how to implement the discipline of oral implantology into their clinical practice. This online course should be merged with a suitable clinical course and long-term mentorship study club program so that the learner can maximize their benefit from the didactic online program. The production of this series of lectures was partially funded by an educational grant from the International Dental Implant Academy. Lecture 11, Long-Term Follow-Up and Maintenance. So a checklist for long-term follow-up and maintenance is as suggested. We usually like to bring patients in, and you can either, if you're the surgical dentist, you can either bring the patient back in. Usually I bring people back in if I'm not doing their regular routine care, and if I'm not providing them with their prosthesis, I'll usually bring them back in at the 6-month to 12-month mark, depending upon the case. But these are the things that we basically look at. We ask the patient if there's any voiced complaints. So are there any concerns that they're having with respect to their dental implants or their prosthesis? Number 2, we check to see that the patient is attending recall appointments as scheduled. There's no point in giving the patient an implant and a prosthesis and then just sending them along their way and then having them come back when things are beyond the point where something can be done. Number 3, we take a look at the peri-implant soft tissues and we ensure that these are healthy. And this can be done by many means, both visually and physically. Visually, we look for tissue redness, we look for inflammation, we look for edema in the tissue, we look for obvious discharge coming from the tissue. Physically, we actually examine the tissue. We will talk a little bit later about probing or not probing implants. Generally, what I like to do is basically take my gloved hand and squeeze the tissues in and around the implants to see if there's going to be any exudate or fluid coming from them. Number 4, we want to ensure that the oral hygiene of the patient is acceptable, and by acceptable, it's do or do not. There is no try. So either a patient has acceptable oral hygiene or they don't have acceptable oral hygiene. I've had a few hygienists say to me that a patient's oral hygiene is okay, and I always ask them what they mean by okay. Number 5, we want to take a look at the prosthesis that the patient has and ensure that it's stable. Also that if it's a removable prosthesis, ensure that it's retentive and that the occlusion is as we wanted it as before, and which leads to number 6, is ensuring that the occlusion is stable. And finally, number 7, if taken, radiographs that confirm stable peri-implant bone and intact prosthetic abutment connections. So, as I'd mentioned, you should follow up if you do an implant for a patient and you don't make an appointment for them to come back. At the bare bones minimum, you should follow up in at least 1 year to take a radiograph to verify the stability of the peri-implant bone and the integrity of all abutment connections. So the schedule of long-term maintenance visits really should be customized for the case, but it can be combined with regular recall appointments and include oral hygiene assessment and appropriate care as well. In particular, peri-implant and hard tissue should be reassessed, as well as the continued stability of dental implants, the prosthesis, and occlusion as mentioned. Patients with a history of parafunction are often candidates for bruxism appliances, and these appliances should be evaluated for their function and wear. I always tell patients, pretty much every patient who I do an implant on, I pretty much include the cost of some sort of a bite plate or parafunctional appliance in the cost of treatment. I pretty much inform every patient that when they receive this bite plate that I'd like for them to bring it to every appointment for 2 reasons. Number 1, so that we can assess the wear on it. Number 2, so that we can clean it in our ultrasonic machines for them. But the reality is you actually want them to bring it to ensure that they're wearing it. And if they're not wearing it, you need to reiterate the importance of wearing this device and remind the patients that they had previously lost teeth as a result potentially of some of these parafunctional habits, Implant patients are usually better than most of my other patients in the sense that these patients have spent a fair amount of money and time, effort, and energy into regaining their ability to chew with teeth, and as such they're a little bit more open to taking suggestions and being a little bit more compliant. However, as we know from studies in sociology, that 3 months is usually the window beyond which you don't want to let people who you're not quite sure if they're going to buy into the program. You perhaps want to bring people back as early as 3 months just to make sure that things are going well. Oral microbiology and oral hygiene protocols, or some reiterating oral hygiene instruction for patients, can also be done at these appointments. So we talk about the implant quality of health scale. So initially, when implants first came onto the market, I remember being a dental student and people telling us that there's a 99% osseointegration rate, and implants are awesome, and patients come in all the time saying, I heard that implants last forever. I heard that implants, they're like teeth that just don't rot. And for those of us who's practiced long enough and who I guess are masters in the field of oral implantology, or as I said in one of the earlier lectures, we're masters because we've seen failure. We have to talk about like what is truly a success. So in the first lecture, we talked about implant history. We talked about some of the criteria that were developed in Harvard. And one of the criteria that was out there for success of various forms of implant systems, and this would be the blade, plate form, ramus frame implants, the transosteal and the endosteal implants, one of the criteria was absence of mobility of 1 millimeter. Now, I mean, in today's day, any mobility of an implant would be considered would be considered a failure. So in terms of the quality of health scale, Mish and a bunch of other clinicians basically devised in 2008 from the ICOI a formula, or sorry, a set of criteria to basically describe implant health as success or optimal health, satisfactory survival, compromised survival, and then lastly failure. So we're going to talk about these in a little bit. So with the implant, the soft tissue interface, we want it to be healthy. We want it to have a normal gingival architecture. As we remember from the earlier lectures, there's no Sharpie's fibers, there's no periodontal ligament around an implant. Basically, you have a long junctional epithelium, and that we've spoken about the importance of trying to maintain keratinized tissue in and around implants, as this tissue can be a little bit more robust to inflammation and for pathogens to cause issues for us. So we want to talk about minimal inflammatory infiltrate and connective tissue, which is closely adapted to the implant. So if we take a look at, once again, this famous picture here of showing the difference between a tooth and an implant. Teeth are similar to implants. However, there's no Sharpie's fibers in the implant, there's no connective tissue, and there's no periodontal ligament. We talked about the long junctional epithelium. These are basically hemidesmosomal attachments that we're relying upon to sort of form a seal between the oral environment and the body. There's also circumferential and perpendicular connective tissue. So when we look at an implant and we look at this periodontal probe, one can appreciate that in a normal tooth, one is basically probing to the base of the pocket, and you're not necessarily getting beyond that connective tissue attachment around the tooth. Whereas with an implant, it's basically a very long junctional epithelium attachment, referring back to that patient who had the zygomatic implants, one can, if you push your probe hard enough and you break these hemidesmosomal attachments, one can actually get to the base of where the implant and implant abutment interface is, and if this is a bone level implant, basically right to the bone level. Bone maturation is basically pre-existing bone which extends into the threads to provide stability, and new bone which is in close apposition to the implant. And this is what we see in this picture right over here, the PB being the pre-existing bone and NB being the new bone which has formed into the implant surface. And we note that new bone deposition occurs approximately as 1 micrometer per day. So this is, what we really want. We want osseointegration of our implants. However, it's not just you place the implants, you wait X period of time, and they osseointegrate. Osseointegration is a bit of a dynamic process. We refer to 3 things here. We talk about the healing phase, the remodeling phase, and a steady state, which have some overlap as well. So the healing phase is anywhere from the day you place the implants up to 12 months. And this can really vary depending upon the patient and their own condition. We talked about in lecture 1 the principle of dynamic reciprocity, so not just how the implant acts on the body, but on how the body acts upon the implant. This in turn plays a role in the remodeling phase, which goes from anywhere from 3 to 18 months, and then basically we hope that the implants are in some form of a steady state with the patient beyond a period of 18 months. These factors will also come into play when one is considering doing immediate load versus early loading versus delayed loading to classical loading, which is done at the 6-month mark. This photograph over here basically demonstrates these 3 things that we discussed and demonstrates that there can be some overlap and that this is a dynamic process. So from the perspective of long-term follow-up and maintenance, what do we have? So we rely upon our colleagues in the hygiene departments and our hygienists in terms of their armamentarium. What do they have for implants? Now everybody knows that you can't take a stainless steel scaler and take that to an implant surface. Basically this would introduce scratches and damage the titanium oxide coating on the implant surface. Scratches would further increase the likelihood of things like plaque and calculus building up on these surfaces. So we have the introduction of a number of things. We have things like plastic scalers, titanium scalers, which are of the same hardness of the implant, so they aren't going to scratch the implant. Rubber tips for ultrasonics, which are disposable, so you can use these on your standard 25, 30K Cavitron tips, and basically these rubber tips will still allow these Cavitrons to function in terms of removing debris from the surfaces of the implants and the bars and prosthetics and all those sorts of things without introducing scratches, and also providing some form of lavage in order to get in order to flush things out. And there's also things like plastic periodontal probes which are out there should you require to probe your implants. So in this photograph here, we're basically demonstrating some of the plastic scaler tips that can be purchased. Hugh Freedy makes some really nice ones. These tips, when you take a look at these, they come in a variety of sizes. So they have a variety of Gracies and curettes and even up to the sickle scalers. And this picture here, you can see some of the titanium scalers that are available on the marketplace. And once again, these come in a variety of Gracies and curettes and sickle scalers as well. In this photograph here, we're basically demonstrating the rubber tips that can be placed onto your standard Cavitron tips. These are disposable and they work really nicely. In this photograph here, we're taking a look at some of the plastic periodontal probes that come on the market. Now, there's different types of probes. Everybody has their favorite, from the World Health Organization PSR probe to the classic, I don't know the name of this probe, but it has the black and yellow marks. So they're usually differentiate between 3 to 3, 6, I believe it's 8 and then 11 millimeters. There's the classic Michigan 10 probe, the UNC 12, and the UNC 15. One day someone's going to have to tell me why they have a UNC 12 and a UNC 15, and for 2 reasons. Number one, the difference between the Michigan 10, I mean, if a tooth has or something has a 10 millimeter probing depth, from a clinical perspective, it really doesn't have any bit better or worse a prognosis than something which is 12 or 15. And the second thing is, the larger the probe, the more difficult it is to articulate or to manipulate in the posterior aspects of the mouth. So if anybody knows the reason why these things are out there, please send me an email and let me know. For some reason, I personally prefer having a Michigan 10 probe in my basic diagnostic kit, but not all of my hygienists seem to prefer the UNC 15 for some reason. So probe, to probe or not to probe. So recall from the discussion on biological width that the value of bleeding on probing is less sensitive with implants. Basically what we want to do is visually look for signs of peri-implant mucositis and also physically look for these things as well. I only probe if I'm suspicious of peri-implant disease. So if I'm looking at the tissues and I'm physically squeezing that tissue and there's some sort of exudate that's coming from there, I will grab my probe and I will take a look. However, if it's the case that a patient doesn't have any of these issues that would raise my my suspicion that something bad is going on, what's the purpose of probing? So we take a look at a patient, this is the patient I was referring to, the patient with the zygomatic implants. I mean, if you were to probe this patient, you would really push hard on this probe, you would be probably able to get all the way down this very long junctional epithelium right down to the level of where these implants at, which is almost at the bone. And the question arises, the tissue may have been healthy, the tissue may have had no issues, there may have been no signs of peri-implant mucositis or peri-implant disease. However, now what you've effectively done is taken oral bacteria and inoculated the area. So from my perspective, if it ain't broke, don't fix it. I usually don't probe my implants unless there's a particular reason to do so. And I've outlined what those reasons for myself are. So in this slide, basically, I'm stating you are interrupting the natural hemidosomal attachment and the long junctional epithelium, or worse, inoculating the junctional epithelium with oral flora. And if you must probe the implants before the other teeth. Dip the probe in peroxide in order to clean it so you're not inoculating the area, or chlorhexidine. And there is a lot of usage of what they refer to as 0.25% sodium hypochlorite rinse. So this isn't like the same sodium hypochlorite that you use in typical endodontic procedures. In this case, what you do is you just take a standard bottle of water, so a 500 milliliter bottle of water, and basically into this, what you're going to do is take 10 milliliters of full strength sodium hypochlorite, and you're going to dilute it, and this is going to give you a 0.25% sodium hypochlorite rinse, which is found to be an excellent rinse. It's approved by the FDA as a mouth rinse for patients. I wouldn't routinely recommend somebody use this every day. However, in the case of implants, in order to prevent things like peri-implant mucositis and worse, the development of things like peri-implantitis, the cytotoxicity of sodium hypochlorite in terms of being able to kill bacteria, and also being something which is commonly available around the world, this makes for an excellent product for us to use in our practices. So the next thing comes into patient hygiene aids. So in terms of what is available for the patient in order to augment their oral hygiene in and around their dental implants, their crowns, bridges, fixed or removable prostheses. So we have a number of things. We're going to talk about 7 things here. We're going to talk about super floss. We're going to talk about end-tufted brushes. We're going to talk about Proxabrushes. We're going to talk about the use of the water pick. Now, with teeth, I wasn't a big fan of using the water pick, but for patients who have either fixed or removable prostheses with bars, the water pick is excellent for lavaging in and around these things. And when these bars are nice and polished and smooth, the water pick is very effective in keeping these areas nice and clean. Mechanical instruments like the Sonicare toothbrush, which doesn't actually has more of a sonic than a mechanical movement with it. Things like the chlorhexidine mouth rinse is available, like Peridex or PerioGuard. And finally, a 0.125% sodium hypochlorite mouth rinse. So once again, like the previous in-office rinse that I had described, as opposed to taking 10 milliliters of the full strength hypochlorite, you're going to take 5 milliliters of the full strength hypochlorite into a 500 ml bottle of water, dilute it, make sure you clearly mark it that this is a 0.125% sodium hypochlorite mouth rinse, and this can be provided for patients who are showing signs of showing signs of peri-implant mucositis, and for them to use for a period of around 2 weeks. Bring them back and take a look and see how things are going. This is a picture demonstrating what super floss looks like. So for those of you who've worked in orthodontics before, super floss is routinely prescribed by orthodontists to keep the area in and around brackets and wires clean. This is an end tuft brush. It has a really nice handle, nice small head. It's easy for getting in and around small areas where there may be fixed or removable prostheses for patients, which goes to the next picture, which is a Proxabrush. It's just a smaller version of an end tuft brush, a little bit easier to get in and under bridges and bars. This is a picture of the water pick. This is a picture of Sonicare. I'm not sponsored by Sonicare, but I love my Sonicare. I have 3 of them. I travel with it wherever I go. You can ask my wife if my Sonicare is not in my travel bag. I'm upset. This was the best Sonicare that I've ever had. It was called the IntelliCleans. Back when Sonicare and Crest first merged together, there was an injectable toothpaste that you could use, and it was awesome. Unfortunately, the whole system was prone to jamming up and gumming up and having all types of mean nasties growing in there, and so this was unfortunately taken off the market. But if you ever have a chance to see one of these, take a look. It was definitely a neat innovation. This is a picture of Peridex, which is on the left, and Colgate's PerioGuard. They're both 0.12 percent chlorhexidine gluconate. And finally, the 0.125% sodium hypochlorite rinse, which you can make in office. I've given the instructions for how to make this, basically 5 ml of full-strength hypochlorite into a 500 ml bottle of water. So I want to talk about our enemies. Recall from lecture 1, we talked about our enemies being three things that cause partial or complete edentulosum. And I cited 3 things. I talked about caries, trauma, and periodontal disease. But really, this definition of our enemies should be broader. Our true enemies in our profession are 2 things. It's disease, which you can sum up as caries, trauma, and periodontal disease. And number 2, ignorance. And the reason I bring this point up here at this point in time is because we battle disease via treatment. Ignorance is something which we have to battle via education. So it's very important to make sure that you provide patients with the time, effort, and energy to educate them about the purposes of why it is what we do. So we get remunerated fairly well in our profession for surgically battling disease via treatment. Unfortunately, the remuneration rates for battling ignorance via education aren't quite the same. I actually have a colleague of mine, Dr. Hettenhausen, who practices in Thunder Bay, Ontario, who has an entire practice which is just based on preventive dentistry. He doesn't pick up a handpiece, and if he picks up a handpiece, he considers it a failure. Kind of a neat thing to mention, but definitely something for us to think about. In our office, we try to make sure that we provide patients with chair time in terms of discussing things about their oral hygiene and their oral hygiene practices. However, we also make sure that we provide them with sufficient handouts, pamphlets, and appropriate follow-up to ensure that this is something that they're going to be buying into. Because we take these beautiful prostheses, like this picture you see here, just an absolutely gorgeous, all zirconia fixed prosthetic for a patient. And we ask these patients to keep these areas nice and clean with these Proxabrushes and water picks and Tuft Brushes and super floss and mouth rinses and all this sort of stuff. Once again, here's another photograph of a patient trying to keep this prosthesis nice and clean. As you can see from this picture, there's actually some thread exposure, and there was probably some history of disease for this particular case, but it's looking good in these photographs. Once again, another picture of a bar for a patient, nice and clean. This lecture is all about long-term follow-up and maintenance. Our next lecture, we're going to start talking about things like management of complications and the worst complication, that being peri-implant diseases. So, oral hygiene in 4 patients, calculus can build up and cause areas of soft tissue inflammation, and this can result in progressive bone loss if left untreated. So the treatment for cases like this is to remove the prosthesis, check the implants for mobility, retorque the abutments, perform maintenance, which is cleaning on the prosthesis and the abutments, and reinsert the prostheses with new screws and give oral hygiene instruction. So the next lecture is going to be on management of complications. As with previous lectures, I've included all of the references that we have used in the fabrication of this lecture series. As I've said in almost every lecture, I would highly encourage people to refer to these references, as some of them are excellent references, and they contain an elaboration on some of the material that I've used them for in this presentation. On behalf of the entire treatment team at Cataraqui Woods Dental Implant Institute, I want to thank you, and we welcome you to the next lecture.